project and the collaborative project between the France and Germany. We have 5 partner institutes and we are working on the how infection is spread in the healthcare system. I will introduce a little bit more thing about it in the later, like what type of infection, what type of the network we will discuss. So before I start about the network infection, I will introduce about my journey. I don't have very big, great background, but I did my bachelor from the State Government University. I know it's very not well known. After that, I started my integrated master degree. It's a 3-year program including the Master of Science and Bachelor of Education. During the master thesis, we decided to start the research. We mean Yogesh is also here, so we 3 people are start together to start research. So during the master thesis, we doing little bit about the mathematical modeling. It was like simple preparatory model. I know you all know very well about it. So apart from the thesis, we published a paper. I was happy to write a publication in the master, but I was not satisfied because I asked to myself, what is it, what I am doing, then is this any impact in the real life? Then I got answer no. Apart from the white paper, it's not any impact in the directly to the society, directly to the in the academics. So that time I realized the importance of the real world data. So after that I decided to do another master degree because in the master degree I did not have experience about the computational things, data, real world data. I did not hear about this type of the world. So I decided to another master degree from University of Leeds in the data science and analytics. After that, in the last November, I joined the PhD at the French School of the Public Health in the France. It's the well-known institute in the public health in France. So we will discuss about what I am doing in the PhD. You can see title like a spread of the HAI and AMR in the healthcare network. I know most of you don't know about the AMR. Can you raise your hand? How many you heard about the AMR? Antimicrobial resistance bacteria. Only 3-4. So I will break down each step. What is network? What is AMR? And how it's work in the disease dynamics. So before I start about the network and infection, I want to ask you one question like why do we need to model? Think yourself and just give me a quick answer like why we are doing. Why do we need to model? Yeah, we need to solve real life problem.
Yes.
It's okay?
Yes.
Because real life system is more complex.
Yes.
So we need to do it by modeling.
Yes.
Is it okay?
Yes.
So I give you example like why, like you can assume like the COVID-19 outbreak. Let's assume another outbreak is happened. First, initially it's happened in the New Delhi, and suppose second outbreak is spread in the NIT Uttarakhand. Which outbreak will be more dangerous? And Delhi, because Delhi is the capital, lot of population. Delhi, Mumbai, you can assume. It's connected by the whole country. NIT Uttarakhand is big but not very separated. So we can't do these things by experiment because we need to be model. Because if we do experiment, it's not ethical or it's not possible. We can't spread the infection for our experiment, for our research. So that's why we need to model. Now I am asking about what is model.
It mimics the actual situation.
Model is approach of long-term area study of any technique or topological problems.
I think sir already discussed about this type of definition. Model are a tool to combine data. Data means what we know, and with assumption and theory, what we can think. And to learn about outcome means what we don't know. Like if I discuss about a particular infectious disease, what we know patient record, in each country it's not possible to record the patient, but some developed country they are recorded to every patient in every hospital or whole country. They have large platform to record this type of the information. And what we can think about how patients are moving, how infection control we can improve, and what's the contact pattern. And what we don't know, we can predict some future spread. We can identify some hidden structure of the infection, where infection is more, when it's less, which hospital are more risky, which area are more risky, which type of the ward in the hospital are more risky. So these type of things we can easily see by the model. You can see like we have real life problem, we have real world data, and by using the model we can get the real life solution. Is it okay for everyone? Why we are doing the model? Now we are start about, sir already talked about the methodology, social network. So now we start about the network. What is the network? I think you all know very well about the network in your bachelor, in your master, or you are from the mathematics background, so you learn about the graph theory and network. So we can see like the Facebook network is a social contact network. How many friends we have? He follow me, I got the follow back. So what type of the connection in the network? Second is the human disease network. We will discuss about more about it. Airline flight networks. And what is the network? Network is the collection of entities that are interconnected with links. Like here we can see the network of the friends. The relationship depends, it could be friends, it could be the professional. So in the network we have two main terms. One is the node. Node is the every individual, it could be any object. Second is the link. What type of the relationship between the node, between the object, what type we have, and how much strong it is. So I think we can see the real life network. You can see the video. Same video.
Can you play it on your screen?
Yeah, but here it's not.
Open your one. Is it PDF or is it PowerPoint?
I just opened on the by link on the YouTube, so I think it will not work.
But can they see it? Can you all see the screen actually?
No.
They are seeing here or what?
No.
You are showing it here, right?
I think
Laptop is sophisticated like this, Yogesh.
in my MacBook I don't have this type of the board.
None of us have a Yogesh laptop. See, Yogesh also doesn't know.
Sorry. So, network is open for everyone. What is network? Node and edge. It depends on what type of the network we are constructing. So we will discuss about it later. What type of the network I construct. You in the last 4 days you know very well about this type of SIR model. You see this type of the models. In last 4 days you are seeing the transmission of the infection. So how it's happened in the real life? Think about it. By movement of the population, Like if everyone is sitting in their home, it is possible to spread the infection? No. So basically it depends on the movement of the populations. Who contact with whom, when and where, which area are more dangerous. If someone go to the infected area, it will be more dangerous. So we need to find the better contact rate. Like in the homogeneous, in the SIR model we assume only homogeneous rate, because in the real life it's not happening. So why we are not talking about that network? Because it depends on your research question and what information you have. Because it's not possible for everyone to such type of the data for whole population or particular group of the population. It's not possible. That's why we are doing the compartment model or SIR model. But I have information of the patient of whole country. So why we are not doing the network model? So in the real life it's not very directly we can't link, so that's why we are moving to the network model. Like best example we can see the spread of the tuberculosis. On the next side you can see the compartment model of the TB model. We can do it. People are doing these type of things. But in the real life we have real data shown by the CDC, with the Center of Infectious Disease Control. And in the real life we can see each dot or patient, and we can see some patients are highly connected. Like you can see only the 35 tuberculosis patients have more than 1,000 connection. But in the SIR model we assume everyone is homogeneous. But here we can see heterogeneity. That's why this is the importance of network model. So we can see most of the patients have few contacts, but a small number of individuals have many contacts. So these individuals are called super spreader. They are major role to spread the tuberculosis or any infection. Second network is like the network of the global aviation network. Is like flight, like how disease spread in the globalized world from one country to another country and one airport to another airport. So it's very good network and it's published in very good paper. And here we can say color represent the number of passengers are transferred from one airport to another airport by the flight, and they are also contribute to the spread of the disease in the global world. So that's why we need to discuss about the network. Yesterday, sir discussed about some complex network like social network, age structure model. We all know about the homogeneous mixing. Discuss about the age structure. This is the same like the social structure. We divide the population according to their demography, according to their age, according to their gender. Third, we will discuss about more detail in the contact network. And yesterday, sir also discussed about the multi-scale model like meta-population model. One country to another country, one city to another city, and one is same like it. And the last one is the agent-based model. It basically depend on the individual behavior, how individual move, and how it's contribute to the spread of the disease. So basically, modeling depend on our research question, what research question we have, what information we have. If we have don't have enough data, we are doing simple compartment modeling. If we have more than that, we are moving to complexity. So now I am discuss about the network model, how we can construct the network. If we go to more complex, some people are doing the agent-based modeling. It is more complex. Now, I think methodology is clear for everyone. We are discuss about the network. Now we will discuss about infection. What type of the infection we will discuss about. Because modeling depend on the what type of the infection. Now I am talking about the AMR, antimicrobial resistance. So everyone heard about antibiotics in real life? You know, if we have some common disease like cold flu, we directly go to medicine or medical center and ask him, give me medicine without any doctor prescription. But it's more danger now in these days and in the upcoming decades, it's more dangerous. Because why is dangerous? Sir already discussed about in the second day drug resistance. You all know about resistance?
Yes.
Means it's antibiotics or any treatment will no longer effective. Means you in the daily life you heard about someone take antibiotics more frequently and more overdose, and we heard about this type of the treatment is not working. It's not working because inside our body we have bacteria, and if we are using antibiotics more frequently and overdose, bacteria are intelligent, they are mutant itself, and they are prepared to resistance of the antibiotics. But problem is not there, because this type of the bacteria don't have any symptoms. So we don't know inside our body we have this type of the bacteria or not. Problem is there, we can spread this type of the bacteria to another person without any symptoms. That's why it's called silent pandemic. People are predicting like in the 2015 it will more dangerous than the cancer. At this time cancer is more dangerous disease. But some people are well known study, they are predict it will more dangerous than cancer. So what is MR? I already told you antimicrobial resistance occurs when bacteria and microorganisms no longer respond to antimicrobial resistance. So inside our body we have this type of the resistance bacteria, we don't have any symptoms, but problem is we can spread this type of the bacteria to another person. So I don't know, I have this type of bacteria, this person is also don't know. I got this type of the bacteria or not. So mostly this type of the bacteria happen in the hospital, because the hospital is the main hub of the antibiotics. They are preserved this type of the bacteria, they are able to spread this type of the bacteria.
Yeah, so if I may.
Yeah, you can add your perspective.
This is very, very important problem. The WHO and any national agencies, even Indian government also, top 5 future problems or current problems include AMR. And these are multiple drug resistance viruses.
True.
And do you recall how is this resistance spread? This is what he was mentioning just a few minutes ago. In hospital systems, how is this infection spread? Any idea? How are these infections spread? Hospital is one of the cleanest environment, I think, right? So then how is this infection spread? Not by cough and cold, because they have isolated rooms sometimes. It could have a common ward where there are many patients, that could be possibility. And yes, coughing can be the reason, but there is other reasons why. Any guesses? Have you guys not seen hospital? You have seen, right?
Process in hospital, like in ward, my family is with me. I am the person on the bed, so I am taking antibiotics. So they can talk to me, or the persons coming to meet me, they can talk.
Okay, the family members. Okay, good. Well, family members can spread. How will they spread? How? I mean, family members are not infected, so how will they spread? You have to think about it. You are saying family members are, but how is that possible?
The instrumentation, they use something.
Correct. So, nurses, doctors, although they are wash their hand, do many rigorous things, patients, they hold the knob, doorknob, they touch some person, they touch beds, all these things, and then someone else who is not infected touches that. That person doesn't get infected, but that person is a carrier to the next bed. And that's how this transmission occurs from one patient. If there are family members coming, they will go out of the hospital. That's not the problem. right? The problem is one patient who is vulnerable because of immune response acting for the reason he is brought to the hospital. The same vulnerable person in another bed, also vulnerable because of other conditions. That's the reason he is inside the hospital. And they both are vulnerable from the immune response perspective, and they are getting infection from each other. It's not like they are not coming in contact and talking to each other, right, typically. So the phenomena is very different. There is a contact, but the contact is not like coming physically close to each other. Rather, there is a carrier that is taking the infection. And it is very important to know that just like regular pathogen spread, there is also resistant pathogens also spread. And resistance occurs in two different ways. Do you guys know how resistance spread? How is resistance spread? And what is the resistance means, by the way? What is resistance means? Let's talk a bit.
Your body does not respond to the medication.
So body is not responding. So basically body not responding means say it again.
Immune system is not responding to medication.
Well, if it is, yeah, so the treatment has certain purpose, right? That's why you are taking the treatment, and there are some symptoms that is not getting resolved, right? So that pathogens are not getting killed, and that probably the toxicity is not enough for that strain to get killed, which earlier was happening, right? So that's a resistance. So the question now comes, if I get a wild type resistance, wild type means which is not resistance to the drug yet. You understand wild type? Have you heard of this word, wild type?
Yes.
So there is resistant type and there is a wild type. Wild type is they are not resistant to the drug. Now, when we say resistance, it is always specific to the drug. It's not like general resistant to everything. It is not all. It's always corresponding to a specific drug that the virus is resistant, right? Now, wild type is the type of a strain of a pathogen on which drugs are working fine. That is why it is called wild type. So now, how does this wild type become a resistant type? Who has this idea, or who can guess on this?
Heredity.
Say it again.
Heredity, genetics.
Genetics of a person
Like
who is infected with this pathogen?
like it can be in your offsprings.
Okay, so but that's a long time process to get to the offspring, right? But this is I'm talking about smaller scale, much smaller scale. So how is the pathogen become a resistant type? Well, wild type is not a resistant virus. That means if you give a drug, if I am infected with a wild type pathogen, so pathogens are terms are two things, wild type or resistant type. Wild type infection, if I am infected with a wild type infection, a pathogen is a virus or protozoa, whatever the, I will, if I take a medicine for that treatment, it will work on me. That means it will kill the pathogen virus because it is a wild type virus. If it is a resistant virus in me, I will take medicine, the medicine will not work on me. Okay, so
these viruses mutate.
right, so there is one way is inside the body mutation happens and viruses change. It's an evolutionary process. Every organism try to adapt to the environment, right? They want to be successful. If you have seen, a documentary on wildlife, you see all animals are trying to be successful in the wildlife. Humans are also. They change their behavior to survive. Same way, pathogens, when they started getting bombarded with the drugs in the patients, they tried to evade They try to avoid those things. How do they do that? There are different mechanisms, but they change their characteristics. So within the same patient, a person gets, the virus changes. That's one way. Another way is that you get from other person the resistant virus. So if I have a resistant virus and Shishchand is here, I might transfer him the resistant virus itself. So that's a two-way that you can get a resistant virus in your body. Okay. So these are basic things, and it's very important when you model antimicrobial resistance. And the mechanism is very, 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 very complex. I mean, I think I will let him explain more details, which I don't know about.
Thank you for explaining also. I think it's not very complex. We are not discussing about complex things like biological things, modeling things. We are just discussing basic things in our daily life. So, first term is the AMR, antimicrobial resistance. Second term is the HAI, is the hospital-acquired infection. Hospital-acquired infection is the infection acquired during the hospitalization, which is main causes of the AMR. So, like in the hospital, if we have more hospital-acquired infection, we are using more antibiotics to prevent the hospital-acquired infection. If we are using the more antibiotics in the hospital, we got the resistance. So both things are working as a feedback loop. So we can use both terms, hospital-acquired infection or AMR. So in the AMR, we have family of the pathogen. We are not discussing about the particular antibiotics and particular resistance bacteria. It's a family of, in the AMR we have lot of virus. So we are not discussing about the particular one. But the WHO presents some study like 7 to 15% of the hospitalized patient acquired at least one hospital-acquired infection during their stay. 7% for the high income setting countries and 15% in the low or middle income countries. And on average, 1 out of 10 affected patients will die from their hospital-acquired infection. And for the ICU ward, it's little bit more dangerous. Like 1 out of 3 ICU patients in the high income settings, like developed countries, affected by at least one hospital-acquired infection. So in the real life, we go to hospital for the treatment, but we don't know we get some acquired because this type of the bacteria don't have any symptoms. Maybe in the future we have this type of the disease, we get the particular antibiotics, and our treatment is not expanding to the control the old disease. And 1 out of the 4 hospital-acquired infection in the long-term acquired care due to the antimicrobial resistance bacteria. So both are working as a feedback loop, as I told you. Now, what I explain about what type of the infection we are discussing. I am explain about the methodology like network. Now I am discussing about what is the hospital network. We know about the network. What is the hospital network? Means the network of the hospital. How infection is spread from one hospital to another hospital. Because we know hospitals are not isolated. They are connected to the public. They are connected to each other. How? By refer the one patient one hospital to another hospital, and by the readmission. One person go to the hospital H1, and after 7 days, the same person go to the hospital H2. So they are indirectly connected. So these type of the study are presented in some countries. I know in the India this type of the record is not possible, but some country this type of the study are presented, like hospitalization note, and how many patient transfer from one hospital to another hospital is called a link. If you have more patient, then we have more good link between the hospital, like we can say by the arrow, the width of the arrow. Like in the day 1 hospital, patient transfer from to each other, simply like the day 2 and day 3. But in the real life, it's more complex. Because of within hospital, what's happened, we don't know. We are only, again we assume. which this hospital is more risky and another is more risky based on the patient transfer. But within the hospital, what's going on, we don't know, because this type of the data is not easy to. Like here we can say basic structure of the healthcare setting. Here we can say hospital act as a driver, as a reservoir, means hospital persists this type of the infection, and the amplifier is able to spread this type of the bacteria. So from here we can see like a patient come to the hospital, they are going to the ward. Within the ward, we are admit more than one patient. Normally it's 7. Like one person is infected, one person is susceptible. They are facing same healthcare staff. They are facing same medical equipment. They are facing same doctor, and they are also facing same contaminated surface in the hospital. And visitors are also coming in the ward. So there is a high probability to transmission this type of the infection within the ward when we are hospitalized. Second, within the second, we can say between the ward, what's going on? Because within the hospital, patient transfer one ward to another ward, like emergency ward to general ward, emergency ward to surgery ward. So within the ward, we transfer the patient. So there is also probability to transmission this type of the bacteria within the ward. As I discussed the between the hospital. In the last slide, I discussed about the between the hospital. So like after the hospitalization setting, patients go to the discharge and it's go to the community. Suppose this patient are acquired this type of the resistance pathogen from the healthcare setting, and we know this type of the pathogen don't have any symptoms. So suppose this patient discharge from the hospital is go to the household, within the home, is go to the community, and it's also interact with the agriculture or the livestock, because in the agriculture we are using lot of antibiotics. In the livestock we are also using lot of antibiotics. So there is also chance to transmit this type of the bacteria from the agriculture or the livestock. So this is the whole process how this cycle works. And this type of the patient again go to the hospital, and this is the main cycle of the transmission of these type of the infection within the healthcare setting. Because healthcare setting is not isolated, that's why we are only targeting hospital setting, because we can't target the general public. It is not easy to model. That's why we only focus on the hospitalized patient or hospital, because it's easy to handle. Okay, this is cycle of the transmission of the infection. Now, I am discuss about my work, what I am doing currently. So, I am introduced about the modeling, which is network. I am introduced about the infection, which type of the infection we are discussing, which is AMR, antimicrobial resistant pathogen. Now, the main important part, the what data we are using. So, we have three component: data, methodology, which network, and which infection I am discussing about. After that, I will discuss about how disease is spread in the network. So first objective is the what data we are using. So in the next slide, I will discuss about how this type of data look like. It's a PMSI, is the database of the France. It's a record the all hospitalized patients of the whole country. And second is network is important, but it's very powerful tool, but it's very important how we construct the network. If the connection are not meaningful, then our network is don't have made no sense. So it's very important how we construct the network, what our criteria to construct the network, what type of the target patient or what type of the target population we are targeting. So in the later slide I will discuss about it. Now, how do AMR bacteria spread through the network, from one patient to another patient, one ward to another ward, one hospital to another hospital, and create a complex network of whole country. So for this I will use the simple SI model. I think it's very easy to for all of you because you are using the complex modeling SIR, SER, but I am using only simple SI model. This is stochastic, so I will discuss about it. Now what that I am using, this is the PMSI, is the French acronym, so I don't get the full form of the PMSI. But basically this is the National Hospital Discharge Database. Here I get the national, means is for the whole country. Hospital discharge, hospital means hospital manage this type of the data. Hospital record the every hospitalized patient come to the hospital. Hospital is responsible to record this type of the patient and send to the agency which is called THI. It's the French agency. They are able to collect this type of the data for the whole country. So here I use the discharge means basically it's the discharge database, like someone admit today is 27 December and the person discharged in the January 5. So basically is the year wise. So this patient record in the 2026 data, not in the 2025. That's why it's called the discharge database. Here in the PMSI we have many categories, but here I only include the hospital which are doing the medicine, surgery and obstetric. It's related to the child care. We are not included in the database about the mental health hospital, or like in the France or developed country we have long-term acute care facility, like some older people they are living there. They are these type of the hospital care of older population. So we are only discuss about this type of the hospital. It's about more than 1500 hospital in the database. It's called all public and private acute care hospital. And originally this database PMSI is designed for the financing of the hospital, because how much finance government need to decide how much finance or resource allocation in that hospital is governed by the database PMSI. But now it's for the public health research is also available. Like I am working in the public health institute, so for me it's very easy to access this database. It's not available for the anyone, for the any university. Like this is the key to access the database. Like I have account in the database, and it's like a OTP of the 6 number. Every 30 seconds this type of the key change the number, and I need to put my account with this type of the number, and I able to access this type of the database. Now, what the meaning of the database? Database means we have lot of information. We have hundreds of tables. So for the managing the database, we need to use the SQL. How many of you heard about SQL? Okay, it's a query language program. It's another language. It's able to handle the database. How we can handle this type of the tables. So basically, I am using 3 types of the table. It's a X, UM, IOM. It's a French. I am told you like this type of the table include the patient pseudonymized patient ID, because in the developed countries every people have the healthcare card. They have social security number. So based on the social security number of every patient, they create the pseudo number for every patient. They create just for the privacy. And if we also have the admission ID, like some patients are visited more frequently, then we have admission ID for the each visited, each time the patient is visited. Hospital ID, which hospital, and site, like some bigger hospital have many sites. Like in the India, some famous hospital have in the different cities. So some bigger hospital have many sites, so we also have detail of the sites. demographic of patient like age, gender, and other details where patient are living. Like in India we call it pin code, and there is called the code geo. This is the residential code of the patient. Date of entry, date of exit in the hospital when patient come, when go out from the hospital. Mode of entry and mode of exit. What the purpose of the hospitalization, which visit of the hospitalization. And another table we have detail of the inside the ward, what's happening inside the hospital. Like some patient transfer from one ward to another ward. So we also have this type of the detail. How many ward patient visited, how many days the patient stay in the ward, what's the category of the ward. It's like emergency ward or surgery ward or ICU ward. So these type of the data we also have. And the third table is the IOM table. We have more detail about the ward, the category of the ward, and how many bed in the ward. We also have this type of the detail. So yeah.
So the important thing here is the database that is you have an access to.
Yeah.
Right? It is not inaccessible to outsider.
Yeah.
So you are working on SQL on that database.
Yeah.
You can't work it on your laptop.
No, it's not possible because the privacy concern. They have particular platform. I log in my ID and put this number, and after that I handle the database.
Okay. So that is very important. So suppose you want to run SQL, you can learn it, but actually working on the database, you need to have a real database somewhere to work on it.
So now we have data. Now it's time to construct the network. We need to identify the meaningful connection. Like we need to identify how infection happens in the real life. So these are my major criteria to construct the patient-based network. Why I am call it the patient-based network? You know about the network. Something is like a connection. Patient-based is a network of the patient. Every node is the patient. Link I will define here. What is the link? So study region is for the whole France, or the national level. Our target group of the all hospitalized patients of the 2023, and we exclude some patient of the outpatient ward. Outpatient means patient visited only for 2 minutes. Like for the cancer patient, radiotherapy and chemotherapy patient, only visited for few minutes because it's a very short time process. Same for the dialysis. So for the meaningful connection, I exclude this type of the because some patient only visited for few minutes. There is less probability to transmission the infection to one patient to another patient and within the hospital. So node is the individual patient apart from this type of the patient outpatient ward, and age is the patient sharing same hospital site, same ward, and overlapping stay periods. Means who he stay with whom, when and where. Like in the same ward, how many patients are stay, we can construct by the network. And I only include the patient should stay more than one night, because some patients only for the day visited, they are admitted only for few hours. So again, I exclude this type of the patient because there is less probability to transmission to infection to each other. So I include this type of the criteria to the network. So everyone is clear for node, what is the node and what is the age. Node, yes, sir.
Here, the edge which you are considering, that is patient to patient, right?
Yeah, yes, sir.
Earlier you quote the example of TB. TB I can spread to anybody, right?
Yeah.
But not completely. That never moving
Yeah, exactly.
what we are considering.
Exactly different. Network modeling depends on the what type of the infection we are studying. I am studying only AMR pathology, not TB and not other diseases.
Got it.
So
And this is undirected.
yeah, this is weighted and directed, because direction is no matter. We are staying together. We don't have any direction. So it's a undirected patient to patient contact network. Now we can see how network look like how this patient-based network look like. So as I told you, this is the patient 1 ID. It's created, it's a pseudo number because of the privacy concern. It's a ID of the patient 1. Ident is the hospital admission ID. You can differentiate both things, like the patient ID and the hospital ID, both are different things. Patient ID is all created only once because it's created by the social security number, like in you can assume like your Aadhaar card number. So patient ID is created only once, but hospital ID is created each time. If you are visited the hospital after 1 month, you have different type of ID. Code geo is like a pin code. Finesse is a called the hospital ID. Finesse geo is also a hospital site, like some bigger hospital have many sites, so it's called the Finesse geo. Num is the number of the ward, in which ward patients are admitted. And this is the patient 2, means this patient and this patient are staying together. When they are start staying together on the 31/2 June 2 of 2023. They are staying together. I don't know who is the patient, but I just showing this the ID. So this is the code geo of the patient 2, like the pin code of the patient 2, pin code of the patient 1. So we have all information about the patient, who contact with whom, when and where. And after that we have all detail of the patient, where they are living, what's the age, what's the gender, and all things. These are the overlapping time when they are start to staying together. This is a type is the category of the ward, like which ward. Number of ward is different and the category of ward is different. It's like an emergency ward, surgery ward, and where it is the number of bed in the particular ward. Here we can see the 22 bed in the ward of the 53 is described in the database. So I will show you later what is the 53, what is which type of the ward. They are staying together 2 days. So we can see how this is just example of the network, because my network is very big. I will show you later. So this is you can imagine how patients are staying together. Now I will show you the flowchart of the construction of the network, like how many patients I had and how many patients in my network. So I start with in the database. I'm only discussing about the 2023. So we have more than 30 million admission and more than 30.7 million patients. Everyone is clear for the differential both in admission and the patient, because some patients are visited multiple times. That's why we have more hospital stay. This is the hospital admission, this is the hospital patient. So in the database we don't have many limitations, but we have some because it's a very rich database. So we have some limitations. So we include this type of the patient. Like I discussed you, I removed this dialysis, radiotherapy, and chemotherapy patient, and this is the invalid ID because there is also some people don't have social security number or like your Aadhaar card, so they don't have this type of the number. So I remove this type of the patient because we don't know about to where. So it's very few, it's not very much. And we also remove the ward with less than 2 beds because 2 patients are staying together. We should have more than 2 beds. So it's not mentioned. So that's why we remove this type of the word. So in the final database. In the final data, we have around more than 13 million hospital stay for the more than 8 million patients. Now, I construct the network. Initially, I construct the network. I have in my network we have more than 8 million patients and more than 304 million interactions between patients. So it's a very huge number. So for the more probability to infection, getting the infection, so I remove the same day infection. So I remove less than 1 day or less. I assume in my assumption, I assume patients stay together more than 1 night. So that's why I remove this type of the infection. And in the final network, I have more than 4 million patients, and it's around 96 million interaction, and we have around more than 1,200 hospitals in the network. So it's very big network. Now the network is the construct. Now it's time to spread the disease in the network. So yeah.
How did you define the interactions?
I already mentioned in the age, like patient stay together, the same hospital, same ward, and same hospital at the same time.
Either one of the, either sharing the same hospital
Yeah.
or same ward
Yeah.
or overlapping.
Or definitely means they are staying together more than one.
Okay, so staying in the same hospital is an interaction.
Same hospital ward. It's not in the hospital. It's a ward.
But hospital site, sharing the hospital site.
Same hospital side, same
And
Plus,
Plus
and.
and.
Okay. Okay.
plus overlapping side.
It's an means unique connect.
Yeah. Now we are thinking about the visualization of the patient-based network. For the visualization, there are many tools to visualization the small network, but you know it's in the network we have millions of patients, so I'm sure there is no tool to visualize this type of network, and it's not make sense to visualize the 4 million patient and 96 million interaction. But I will show you the example how network look like. I visualize the network only for the one city for the better understanding of you. Like this is the visualization only for one day, like the 30th April, and it's visualized by the Geki. Geki is the software to very easy to visualize this type of the network. So here we can say every dot represent the patient, and every color represent the hospital. Like we can say this is the ward, and within the ward on the 30th April, every patient are connected to each other. Is it okay? Same, it's like a ward of the another hospital. See, it's a ward of another hospital. But all are separated. All wards are separated. Why?
Because in the data you take different types of data.
No, same like this is the ward of this. This is same color, means they are both are in the same hospital. Maybe two ward 1 or ward 2. Why they are not connected?
because that is the assumption you took in the beginning.
That is
This is
a
one
it's
day.
a day network, only for one day.
One day, yeah.
And in our assumption, we assume patient stay together more
More than one day.
So
So this will be, think about this, will color code changes, color code if we
Exactly.
have a movie
exactly.
for moving in a time,
Yeah.
this color coding will change
Yeah.
and move around.
Yeah. So in the next, you can see I visualize the week network, like April 20 to 28. Now we can see what is this. This
So,
is the
so
host.
what was the interaction in the week? Is any time once or continuous in that week?
Continuous.
No. So your interaction is in the same word, right?
Yeah.
Same word.
Yeah.
Same word for the whole week
Yeah. Same.
or any day of the week?
Any day of the week.
Any day of the
That's
week.
why, like this patient, maybe in the first 2 days, he
Okay, fine.
this patient was in this hospital. After that, he moved to the another.
The thing what I'm saying is the definition of interaction is very key here.
Yeah.
Otherwise, the network will be very different.
Yeah, as I mentioned, network is powerful, but it's very important to how to construct the network, because we need to identify the meaningful connection. So here we can say, here
So in this you covered all the data, or it is only sample?
it's only for sample,
1 week.
because it's only for
In one city.
It's
one
only for
state.
70 members.
So why sample? What do you mean by sample?
He's asking about is my final network or it's only for the sample? So I plot only for the sample because in final network I have more than 4 million patients. So it's
Okay,
not
okay,
enough.
okay. Not all patients.
So I just to visualize you think about how patients are connected. That's why I upload it.
And what software you are using?
I mentioned it's a Getty.
Getty, okay. And this is a free software?
Yeah, it's free.
Free software.
So I think you can visualize the network or this one network. It's very,
So,
very
but in the Getty, you are taking a sample, so you're not taking the original data.
yeah, it's not possible because of privacy concern.
Privacy plus it is a huge also.
Usually it's not.
Yeah, it's a both of them.
Now here my point is like how what to what connected, hospital to hospital connected, how it's connected. Because I construct the patient-based network, but here you can see how hospital are connected. Maybe because this type of the patient in the first like assume in the first day of the week it's admitted this hospital and later it's admitted to another hospital. So we can assume like hospital, healthcare setting and within the ward, within the
Ward shifting as well as.
all are connected. That's my point. Like here I assume for the whole affair is like more.
Yeah, it is very important to define interaction here. This is also very, because if you change this thing, the network characteristic will change. The network itself will change. And this is a made up definition. I'll tell you, I mean, of course, logically made up. It is, they have made this definition, but it's not a standard definition that everyone does the same way. There's other ways you can define the same definition.
And it's also depend on the what type of the infection we are studying.
Correct. And so, which would more, I mean, you are taking weekly network for your analysis, or you are taking daily network, or?
It's just for visualization. In my final analysis, I took the whole network over me.
Whole network.
It's just for visualization.
Yeah. And you were working where for the whole network?
Yeah. Like in the spreading process, I now it's time to spread the disease in the network. Like I am talking about 1 year, 2023. So I divided my network day by day. Like I show you here, the day network is like this. So here I divided my network in the all 365 days. Here we can say is the day 1, day 2, day 3, all day 3. Every dot represents the patient, is a ward, all are connected. Now it's time to spread the disease because everyone is not risky. Like someone, this patient is infected, so it's not possible to infect everyone. Maybe one of them are chance to getting the infection, but not all. So that's why we are using the stochastic here. We will discuss about the probability. So it's called the temporal network because it's depend on the time. So like in the simulation first we assume only 2 patients are infected. Suppose these patients are infected. Now we need to think about what's the probability of getting infection from this patient. Is it good? Okay. Like here I assume what's the probability of becoming infected. Here we assume the constant probability. Only 10% probability to getting infection from here. Suppose these patients have 10% probability. After that, I assume a random number from between 0 to 1. And if random number less than 1 by 10, then I mark if the patient is infected. So it's like a coin. Like if I toss the coin, if less than the 1 by 10, then I mark this type of the patient are infected. So out of 4, maybe I get one patient infected, 2, 3. It depends on the simulation. Now, if we have more neighborhood are infected, then we have more probability to getting infection. If we have, like here we can say 3 patients are infected, so all 3 are high probability. So I just define the basic probability, which depend on the neighborhood. If we have more neighborhood, we have more probability to getting infection. So everyone is clear how I define the probability of getting infection. I am just talking about the simulation one. It's a stochastic, so I will run the another simulation.
What is your neighbor? Neighbor is immediate connection.
Yeah.
So
It's a day by day.
it's got day by day network. But what is the edge? Edge is
Staying together at the same hospital.
same itself. So neighbor is if they are same ward.
Yeah.
That's a neighbor.
Yeah. This is what.
There is an edge between two nodes, then it will be called network.
Sorry.
I'm saying if there is an edge between two nodes, then we will consider it.
Yeah.
If there is no edge,
Yeah. Yeah. So this is basic probability to getting infection. Now I do for the all another days, like the day 3, day 4, and all 365 days. Okay. And I complete my simulation, like a simulation work for the all 365 days, and define which patients are infected, because here I only marked infected or not, like 0 or 1, the patient infected or not. So I did for the first simulation for all 365 days. Now the another simulation I start same process but from another days, not from the day one. Because in the real life we don't know when outbreak will start or within the year. Yeah.
It is about simulation. What is simulation?
Simulation is like I calculate the probability, like from the day one I assume like this patient are infected. Now I need to getting the probability of infection. How much is that? Like I assume the only constant probability 10% chance. If then I choose the random number. If random number less than 1 by 10, then I mark what is infected. So it's completely random. So
These are rules.
huh?
Like for simulation, these are rules.
The question is, how do you get beta? How do you choose 10%? I mean, this is
Yeah.
based on certain criteria.
No, here my focus, we can choose another beta. It will impact only on the number of infected patients. But my interest is not in the number. I want to structure of the network, like in the special structure.
Okay.
What is the probability or risk of the particular area, particular hospital, particular one. So I'm not interested in the number. It will only impact in the number.
Okay.
If we choose more beta and we got a lot of patients are infected. And basically it depends on the petazone, what petazone we are discussing.
That's fine.
But my approach is petazone agnostic. So I just want to,
So what is your outcome here? What are you made? Eventually, what you will
in the next slide I will.
Now
I
I will start from G1 and there are 10 nodes. That's what I can see. There may be a reason for considering this probability as 1 by 10.
I'm just saying 1 by 10 or beta is depends on the petazone. Like if some petazone are more risky, we need to choose a high beta. In the AMR is family of the petazone. Some petazone have very quickly spread and some have very few probability. So it will only impact on the number of infected patients. But it's not a real outbreak. I'm just spreading the disease and want to learn about what the dynamics of the network and what the dynamics of the infection.
Right now, it is arbitrary.
Yeah.
There is no meaning of beta estimate.
Yeah.
10 has no meaning.
Yeah.
But once the disease will be there, it has a meaning.
Yeah.
But it could be made more sophisticated by asking the way you are defining interaction. The beta could be more finer. Disease will also impact, and the definition of interaction will also impact beta. And it could make, you can estimate it using, but that's not his goal.
Yeah.
What he's also claiming is, you don't have to really worry about it, because his goal is something different, which he will going to tell in few minutes.
I know you are worried about the parameter because in the compartment model you choose the fixed value of the parameter. But say here I am sure it's not a problem of the why I choose 1/10. I will show you later in my result. Now I like in the simulation one I run for the all 365 day. Yeah. Here I did 2000 simulation and every simulation start from the random day. This is most important. Yeah, because in the real life we don't know about when outbreak will start. So it's no matter when outbreak start, it's no matter what weather zone time is. So here I did 2000 simulation and every run start from the random day with the cyclic sequence like after 31 December, it's again start from the January. So everyone is clear how it's cycle is working. I did this is very computational things. It's not easy to compute this type of the probability. I did this in the cluster, which is the high programming computing. How many of you know about the cluster?
And this is a very important point. So
Yeah.
because he's not doing bifurcation in like the way we think. So it is computational real life models, and real life model doesn't require the tool to be same tool to use. I mean, it depends on what is the need, and based on that one as the analysis.
So we provide task and data, and there is some clusters available anywhere.
Cluster means we have collection of computers.
Yeah.
We have lot of CPU. It's a big machine. So I run my code in the 18 hours if I use the 32 CPU. If 32 CPU are working parallelly, then I took 18 hours for this simulation.
So this is very good point you are making. Thank you for bringing it in. How many of you have used high performance computing, HPC? Okay, so only 2 folks raised hand, and it is a need of a day to day. Okay, I don't know where you can get access in India. I'm not aware, but in US there are organizations that provide for students access and learning to the high performance. Until you put your hand dirty in it, you would not really understand how these things will work, because it requires coding and parallel computing of certain tasks, which is not sophisticated. First time, yes, it is difficult, but once you do it, it is a repetitive task, and you are not doing it. It is a computing facility that is computing it, but it costs money. The computing facility costs money. So what software you are using? What software you are using?
Yes, for Genuist is the local software, the French software.
Yeah, but
It's basically for the bioinformatics.
yeah. So, but you are not coding it in anything? C++? Or
Yeah, I write my some function in the C++.
C++. So C++ is going, and then you have to put a header to talk to the HPC. The HPC is a big computer basically that is doing. So you have to. So he has the C code with the model, these probabilities and all these things, and connecting to the network, and then he has this header that goes and that connect his code C++ with this big machine, right? And that header is typically standard, but it also depends on your code, the way you have written. So that's very key actually. What software you both are using?
We were using Linux for making the servers,
And Linux is
Basically,
the operating system, right?
basically all software are working on the Linux.
Yeah.
there was some local software in IIT Bangalore. I don't know.
Okay, fine.
Most of people are using this.
Yeah.
So in my case, for some stochastic simulations, I was using a sort of supercomputer which is provided by the library, but the codes were basics in MATLAB, but I used that because the stochastic is like
So-
a lot of time in normal computers.
So that means your software, your high performance computing facility had a compiler of MATLAB as well.
Yes.
Because you need a compiler for high performance computing for that language. C++, C are standard, even Python is standard, but I was not sure about MATLAB. So some instructions is given by these big machines also. I mean, organizations that have these big machines, big servers, they give you instructions to work with your code. So it is not difficult, it is not that extensive difficult, it can be easily managed. But you have to learn how to connect that. You were saying something? No. Okay, I think it is clear some idea you have got. So try to see, many institutions do have high performance computing, like I was in IIT Kanpur and IIT Kanpur has HPC, and it gives your school also. I think most schools have it, but they may not give you facility to use it. You have to really request for it and to show the purpose of it. And also, you know, there may not be a big cluster. It might be a small cluster, which is fine, 4 or 5 computers, which is okay. But you will get an idea about how to interact and work with it. This is today's important skill set.
Now I am already mentioned about why I am using only SI model, because it's depend on the what type of the infection we are discussing. So I am only discuss about the AMR or HI. So it has lot of pathogen. So I don't know about the specific infectious period for each pathogen. That's why I use the SI model, because I don't know the recovery period of the pathogen, because it's very from short to longer. And second reason is also like why I'm using SI, because network is very complex and very large. So I want to make sure the reachability of the infection from here to there. This is also important. That's why it's the simple reason of I am using the SI model. And what is the output of the simulation? Like in the simulation, we define patient is infected or not, 0 or 1. For each simulation, how many simulation? I did 2000 simulation. So for every simulation, I have detail of all for more than 4 million patients, which patients are infected or not. Now we need to find the probability of infection, overall probability, because it's stochastic. So we can't define from the only one simulation. We need to take average from all 2000 simulation. Here I use the probability of colonization, not using the infection word, because it's not spreading the disease. Colonization means inside our body we have this type of the bacteria, and we don't have symptoms, and we don't also have any disease. That's why it's the colonized bacteria inside our body. So you can see it's like a risk of infection. It's similar like a colonization risk. So it's defined by the number of simulation in which the patient become colonized or infect, divided by total number of simulation. It's very simple. It's like just take an average. So from there I can count the probability of infection or probability of colonization for each 4 million patient. Is it okay for everyone? Now I track these patients, where they are admitted, in which hospital, in which ward, where they are living. Based on these patients, I found that probability of colonization based on the hospital, ward, and the residence code. So this is my first result. We can see where these type of the patients are living. Basically, each cell is called the Voronoi cell. I don't know if you heard about it. It's called the Voronoi. So each polygon represents the Voronoi cell, and it represents the code geo. It's like a pin code. It's like a pin code of whole country. So from here we can find where is the risk. We can find the colonization risk, just taking average like how many patients in our network from the particular pin code or code geo or polygon, and we can see two variables. One is the colonization risk ratio, how much is like If we have more red color, we can say more colonization risk. Here another variable is the how many patient in the particular pin code, particular code geo, or particular cell. So it's defined by the blue color. If we here we can say like if we have blue color means we have lot of patient in the particular region, but we don't have risk because we have colonization risk is low. If we have high patient and high colonization means we have more darker region. So from here we can identify the geographical region which are more risky. It is very important for the preventing the infection or the public health planning to control these type of the infection. Can you think about why these type of cluster means these type of the area are high risky? Would you think about it?
Population density.
Population density, that's good. Second, do you have some other factor? What's the reason behind it?
Yeah.
Hmm?
So the darkest region is so one thing is that
Yeah, it's correct. It's population.
on the disease or the antibiotic that is used and which is more resistant.
Yeah, we are showing this type of thing, but why? What's the factor behind it?
Showing the colonized, the patient will colonize this.
Yeah,
They have the chance.
because here we can easily see this type of the area are not risky, and this type of area also risky or not risky. So this point is correct. Like we should think about the population density. It's correct factor. Another factor, do you have in mind?
The urban, rural, something.
Yeah, it's
Like
same
the
as population.
people.
It's same as population
Yeah.
density. Yeah, like here we can say it's a Paris. If you know about it, it's a highly populated city. But here is risk, but we can say not very west, because it's very small. But now we think about the population density. Yeah.
Maybe the more brighter ones are the areas where people are more frequently hospitalized or going to sharing
That's
in
the point.
the sharing
Maybe
units.
this type of the area, this type of the patient living in these area are more frequently visited in the hospital. Maybe they are staying longer in the hospital. So we will check this factor. What is it?
This is Paris, right?
Yeah, here is Paris.
Paris is up there, yeah. There.
Here I am living.
Yeah, he is on the.
It's more risky. I am living in the dangerous area.
But is it a way to check
What is
that?
that? This
The,
like Sri Lanka in India.
no, this is island,
No, it's another island of
which is French territory.
part of it.
Yeah.
Now we need to think about the population density. So here we can say each dot represent the geography of the patient, where patient are living, and color represent the risk, same as we discussed in the last slide. If we have more red means we have higher risk of the colonization, and the size of the point is depend on the population density. Means we have bigger dot, we have highly populated area. So this is Paris, you can say, and this is the medium risk. And see, these are highly populated city, but risk is lower. You can say blue color here, 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 and you can say these are the rural area, very small dot, but here these are also higher risky. So your point is here is not correct. This not totally depend on the population density. Here we can discard these things. So we need to think about more about it. So these are the factors. Like it's the same plot of the population density. You can say it's called Voronoi map. It's same as it's not changed anymore. So population density is not a bigger factor. But here we can say is the colonization risk based on the standardized average of the whole country. So here we can say it increases with respect to number of ward visited by the patient. How many ward visited by the patient? Some patients are visited 10 ward, they are more risky. We can say here. Another factor is the degree of the patient. How many of you know about degree? Connection of the patient.
Yeah.
How many patients are connected to the particular patient? So degree is also factor, and length of stay in the ward. How many, if a patient stays longer in the ward, there is a high risk of the colonization. So here we can say these are the factors. Now we can identify which ward is more risky. This is called the lollipop map. And here we can say these are the ward and the category and number of the patient in the ward. And this is the risk of colonization risk. And this is the standardized by taking the average from the whole ward. And we can see these type of the ward are from the average they are more than two time high risky. So it's very important again to, if we are planning to within the hospital, what's the reason behind this type of infection? So we can target this type of the ward. We can provide the facility this type of the ward, like based on the resource allocation, hand wash and sanitization, all things. So it's very important for public health planning, infection control, and see like this ward is not here we have only a few patients, but here is risky. So you can't say if a ward have more patients, then it's automatically is a high risky. Some small ward is also are high risky. The size of dot represent how many patients in the ward, and color represent the risk. Is this clear for you? Okay. Same is for the hospital. From here we can identify which geographical region hospital are more risky. So you can say this type of in this area hospital are more risky, they are not risky. It's same like we discussed in the last result. Maybe I'm taking longer time, so I need to finish it. So the take home message is like here I construct the first nationwide network. According to my knowledge, is the first study for this type of the network, this type of the data. Maybe sir you know better about it. I did not find any study regarding this. So this is the first study, high resolution network, patient-based network linking more than 4 billion hospitalized patients to track how MR bacteria spread through the real hospital movement based on the potential connection between the patients. Network structure also, here we did not discuss about the particular pathogen. It's a pathogen agnostic approach, but still we have some meaningful structure. We can, for the public health planning, for the infection control, we can do something like it. We have some message. So for the public health insight, this pathogen agnostic approach enable early identification of the high risky ward or region. Before outbreak start, we can do some prevention for the particular ward, particular region. So this is the main result or message. As I mentioned, we also have limitation because in the network we did not consider the outpatient ward. Like we exclude the cancer patient because they are visited only few times. But in the real life scenario, cancer patients are more risky to spread these type of infection. So I'm sure if this is the limitation, we will think about it, how we will consider this type of the patient. And here we did not assume ward level risk, like which ward are more risky and which are less risky. We assume all ward are risky, but here risk depends on the patient connection. In the next step, we have some planning to do after this study. And for this study, I am very thankful to my project partners, data providers, high programming computer software, and thank you all of you for listening me. And it was a pleasure to meet all of you. Yeah. Thank you.
this is an amazing project and not very difficult, very, very practical problems that can be, the results can be used directly in the policy making. Now the question comes, can we all do this type of project?
Yes.
Yeah? But how?
We have the data.
Yeah.
How do you get data at the hospital level, discharge data?
Okay, that's a good question you are asking, but what is the answers to those questions? Where will we get access to that?
You can go to the authority.
Which authority? Well, it
We
is.
also have another option. We can generate synthetic data. In the yesterday's I told you. We can generate any type of the data.
Synthetic data, what that exactly means?
Synthetic data means we generate the data from the artificial intelligence, you can see, or by using some package or by using these characteristics.
Yeah, synthetic data.
We can generate data.
Yeah.
Validation, for validation we need to find.
Yeah, these are the validation and these things comes later.
Yeah.
And when things comes in face of you, you resolve your issues, you find the problems to that. But coming back to the data, that is most important thing because otherwise you can't begin the project. So synthetic data is one way, and synthetic data is you are generating your data by yourself, but you have to give some characteristics. For example, what is the age group of this network? What is the gender distribution? What is the comorbidities of these populations? It has to come from somewhere. Now, you may generate this. So this is a good point. I mean, you can generate a pipeline without actually truly having the real data, but make your own things without really, and that is one way to do it by using synthetic data. So synthetic data algorithms are there online. I mean, it's not difficult to find it if you are really interested in that. Now, some characteristics, you can't make it a best data out of it, but at least some data you can make, and that could be your research. Research is not about really solving today's world problem. Research is about, in India there is not this pipeline for students are available. You can generate this pipeline yourself using synthetic data. Now suppose you synthetic data, you don't have it. Then what do you do? Where do you get this data, something data like this?
ICMR reports.
I have tried in TANSEC actually.
Say it again?
TANSEC is I began when I was there in the first year of my PhD. I wanted to work on HID children. So what benefits, and that was my first interest of study. So HID, it's a very highly sensitive data. So I approached to TANSEC in Tamil Nadu. It's situated in Egmont.
Beautiful answer. This is what I was expecting. Approached.
Yeah.
If you do not